Thank you so much for joining us in our Advances in Autism Research and Care webinar today. We're going to give people 1 or 2 more minutes to kind of roll in, and then we'll do some housekeeping and get started. Thanks so much. All right, we're going to go ahead and get started. I'm so excited. We're going to welcome Dr. Rachel Loftin as our presenter today. She's going to be presenting on sexuality and sexual health in adolescents with autism. Dr. Loftin is a clinical and school psychologist who specializes in autism spectrum disorder. She has extensive experience in diagnosis, assessment, and intervention to help promote positive outcomes for people with ASD. Dr. Loftin is adjunct faculty in the Department of Psychiatry at Yale School of Medicine and was previously an associate professor in the Department of Psychiatry at Rush University Medical Center. Dr. Loftin's clinical research interests include interventions to increase independent function in young adults, strategies for increasing self-monitoring, and sexuality education and sexual identity in people with ASD. We're just a few housekeeping notes. If you look over to the right side of your screen, you'll see a little questions pull down. If questions ever come up during the presentation, feel free to type them in, and then at the end, I'll be able to ask them of Dr. Loftin, and she can hopefully have a little back and forth with us. Without further ado, we're going to welcome Rachel. Thanks so much.
Hi, everybody. Thank you for listening to my talk. I hope to keep it interesting and very practical. But because I'm trying to focus on keeping it practical and we are limited to an hour, there are going to be a number of topics where I just kind of skirt around them and I'm not able to be as complete as I would like. So I look forward to your questions at the end so that I can get into more detail about anything that would be particularly useful for you. I'm going to go ahead and go to the plan for discussion slide. So today, my plan is to give that broad overview that hopefully will help inform your work with patients and families. We're going to start off by talking about what we know about sexuality and ASD. And even before that, I'm going to back up and give some reasons why what we know remains pretty limited. And then I'd like to briefly make the case for promoting sexual health. Hopefully we don't have to spend too long on that because most of us, I think, already value that and understand why it's a worthwhile endeavor, but I want to make sure and point out some of the key reasons it's important. Then I'd like to focus on where breakdowns often occur during the development of sexuality and ASD. So what are the stumbling blocks that get in the way of healthy sexuality? And then finally, I want to give some very specific recommendations for working with families and the content to teach. There are going to be a few slides. You know, I use the word graphic in my slide. I wouldn't even call them graphic, but maybe a little bit upsetting. Nothing is too graphic and nothing's gratuitous, but I wanted to give that warning and so you're not surprised. Going on to the background slide, just wanted to give you a couple of pieces of information about my perspective and where I'm coming from with this presentation, because it's a little different, I think, from most people who present on sexuality. As you already heard, I'm not a sexuality specialist, I'm an autism specialist. And so really what happened over the years, I'd say in the last 10 years or so, my practice became increasingly focused on adolescents and adults. And as it did, what I found was most patients were coming and asking how they could get a girlfriend or a boyfriend, or they were saying that they feel really lonely, or their caregivers were complaining about problems related to sexuality or privacy or other topics related to this. And at the same time, I started to get calls from attorneys who were running into people with autism who had been arrested for sexual crimes. So what I was seeing is both, people with autism asking for information, asking for the tools that they need to have healthy relationships and healthy sexuality. And I was seeing the outcome of what potentially could happen if they don't get it. And so that combination of factors really got me interested in the topic, and I tried to gather as much information and do what I could to help there. So as part of that, I have a general ASD practice, focused on all the things you would expect a psychologist to be doing. But my work through Yale that was mentioned is in the Division of Law and Psychiatry. And there we've started a specialty clinic where we're focused only on referrals for people with developmental disabilities. So any kind of developmental disability, but the calls we get most often are related to people with autism who have committed a sexual offense. We'll see other things, we see violent crimes and other things as well, but that's the kind of call we get most often. So I'm going to try to be focused on talking about, positive and healthy sexuality for its own sake, because I think that's a very important topic. But because of the work I do, I might have a rather cautionary tone and focus a bit as well on the prevention of the problem behaviors that can develop. I'm not going to talk about biological maturation, the more biological processes. I'm going to be focused on the psychological development. And then finally, the last thing I want to say by way of background is that almost everything we talk about today could apply pretty broadly to people who don't have autism as well. I once gave a talk on autism at a sexuality education conference that was not autism focused. And I had a number of the educators come up to me afterward and say, everything you said applies to everyone. And that was a kind of an aha moment for me, because I think sometimes we break things down and think more carefully when we're trying to teach individuals with autism, and we forget how much many of us would benefit from, clearer instruction and some of the other things we'll talk about. I think the difference in our population, though, is that people with autism require a higher degree of clarity, a higher degree of sometimes concreteness or explicit instruction than the general population. But otherwise, almost all of these issues apply for everyone. Going to my next slide here, which are the types of referrals that come in. Really, we can narrow it down to two categories. Caregivers or people on the spectrum themselves are either already worried about sex or they need to be, because these are issues that really are affecting everybody across the board. So the issues that come in most often among the people who are already worried about sex, obviously, if the individual's been arrested, they're worried. If the individual has gotten in trouble at school, I'm sure a lot of you have dealt with patients who are grabbing indiscriminately or pulling their pants down or masturbating in inappropriate locations. Those kinds of things that get one in trouble at school. Very often, just people who are dating or trying to date and having trouble figuring out how to do that. And then sometimes there are sexualized behaviors that happen at home, much like those I noted at school, and that's what brings people in. Those who are not yet worried about sex often have excuses. So parents in particular who are not doing sexuality education with their kids or not beginning to talk to their kids about these topics will often say, he's just not that interested. He still likes Barney. Why should I talk to him about sex? It's not even on his radar. He's still so childish. And so I think a lot of parents have an urge to protect. And a lot of parents don't want to think that their child ever will be sexually active or want to be sexually active, such as the parent who says, oh, my daughter's never going to have a partner anyway, so why would she need to learn that? And of course, there are a lot of answers and a lot of rebuttals to those comments, but I think one of the most important is it's a human right just to understand your body and understand what's happening. And it's particularly important to protect oneself from victimization. And that, of course, is going to be the biggest risk as we talk about things that could go wrong with sexuality and autism. So here on the next slide, I want to talk about what we already do know about sexuality and autism. It's a really exciting time in sexuality research. Even just 2 years ago, we had such limited information, and now it's really starting to emerge. And so there's really interesting data coming out of the Netherlands. There's really cool work happening in Australia, and I'll talk about some of this, and it's really adding to what we know and what we understand. But we still have very few studies, so we're talking about, you know, a really limited amount of information. A big meta-analysis that I'll reference a couple times today out of Australia, it's the Hancock, Stokes, and Mesabov 2017 reference. Really, in their whole meta-analysis, ended up being able to use only 9 studies. So that gives you a sense of what we're dealing with. And they were trying to look broadly at all sociosexual topics. But some of the problems that we encounter with the studies that we do have, and in particular the older studies, one, which affects all of autism research, of course, is the diagnostic categories, how those are shifted over time, how we don't have clear information about how the subjects were presenting, and a lot of times we have very high individuals lumped in a category with individuals who have intellectual disability or other confounding issues. So that makes it very difficult to know what we're dealing with some of the studies. Sources of information are a really big concern, and I find it really amusing that a lot of the older studies talk to parents and caregivers, and that was their sole source of information when they were trying to collect sexuality information about individuals. So when I give talks out in the community, this is the point where I always turn to everybody and I say, hey, what if I asked your mom in college about your sex life? How much would she really know? And the point is, you know, people with autism may have privacy. They may have things happening for themselves, or thoughts or beliefs or experiences that they're not sharing with their parents. So while we can get some information from caregivers, it really was a problem that they were relied on as a sole source of information. Sample severity is an issue. A lot of the older studies were really focused on people living in group homes. So people who had maybe a more severe presentation and required a specialized placement. Likewise, a deviant focus. So a lot of the early studies were focused on really unusual problem behaviors. And until recently, we've had very little information about healthy, normal sexuality in autism and what that looks like. And so the studies I've mentioned from the Netherlands, this is a young man in particular named Gerard de Winter, and I'm sure I'm butchering his name because I don't speak Dutch, but he's done some really great studies recently looking at healthy sexuality, normal sexual behaviors in autism and what that means, and just kind of helping us define that. And then the methodological problems. You know, so many of the things available to us in the literature are case studies, or the studies that do exist are just kind of poorly put together out of necessity, of course. You're talking about really difficult studies to put together. Okay, now I'm going to move on to the next slide, which is benefits of encouraging healthy sexuality and autism. And I didn't organize this as clearly as I perhaps should have, but on the left, the column on the left is discussing benefits, the column on the right, kind of the opposite. So what happens if we haven't put these benefits in place? And so I think the most obvious thing you get, if you're encouraging healthy sexuality, you're doing what it takes to encourage it and develop it, then you get healthier behaviors, which results in a healthier population. Ideally, and most likely, you would also get more meaningful intimate relationships. Sexuality is a key feature of intimate relationships, and so if people have better skills and more healthy sexual behaviors, you would expect those relationships to improve. So increase in sexual pleasure, which in the typically developing population has been associated with stress reduction and other health benefits. And then something I really like to see more research on in autism is whether having healthier sexuality, having more relationships and more meaningful relationships would also maybe mitigate some psychiatric symptoms. I don't think the comorbid psychiatric conditions would go away necessarily, but you can imagine a reduction in depression, a reduction in anxiety, and perhaps other psychiatric disorders if a person were involved in a healthy, intimate relationship. So the flip side of that, of course, we've all seen people with autism who are yearning for an intimate relationship and feeling very lonely, feeling very isolated and not having those relationships. And that really increased risks. Risk of suicide, of course, goes up exponentially with isolation, but risk of depression and other unhealthy behaviors also increases. Without the encouragement of healthy sexuality, you see a lot more difficulty within relationships. So if somebody with autism is able to attain a relationship but hasn't learned about consent or hasn't learned about active listening and respectful communication, a lot of difficulty might happen there in that relationship. And of course, the biggest risk facing anybody with a developmental disability is the risk of victimization. That's something I really can't overstate. And education and helping understand healthy sexuality is exactly how you help prevent victimization. And also there's a risk, albeit much lower, of perpetration. So there's a lot of unintentional sexual crime that's committed by people with autism when they don't necessarily set out to hurt someone, but they don't fully understand sexuality. They don't understand the impact of their behaviors. And so promoting and encouraging healthy sexuality could go a long way toward preventing the unintentional perpetration. Going down to the definitions of sexual health slide, I put up here the CDC's vision statement regarding healthy sexuality. How much this is put into practice is a different story, but you know, the current vision statement for the CDC regarding healthy sexuality is, you know, that they'd like to use a public health approach to promote age-appropriate sexual health, consistent with the best available science, including healthy and responsible sexual behaviors for all Americans over their life course. They go on then on the same webpage to cite the World Health Organization sexual rights. This is a statement that came out a couple years ago, and I've kind of spelled out the gist of it on the next slide. But this is how the World Health Organization defines the sexual rights, sexual health that people are entitled to. I'm not going to read through all of these, but if you'd like, in the resources, I include a link to the World Health Organization webpage where they discuss this, and also to a paper that a colleague and I wrote about how these rights apply in people with ASD and what might be different in where the areas of need are. I put this up here though, these definitions of sexual health, so that we can start to think about how broad this is. This isn't just, you know, sexual education about the mechanics of reproduction, right? It's a much more broad and social construct that's being discussed when we talk about sexual health. I think that's really important when we're talking about autism, because as we know, teaching broad constructs and making sure that people with autism understand and can conceptualize these broad ideas is a real challenge. And hopefully, as we get talking here, I can help show you some ways to make sure that it's more globally addressed for your patients. So the next slide is one where I boil down a little bit. You know, we've got that long list of the World Health Organization rights, and I boiled down where are some of the key areas where that might break down in ASD. So what are some of the biggest barriers to healthy sexuality and autism? I'm not going to be able to give you a comprehensive list, but I think a lot of the barriers that exist fall into one of these three categories. Failures in sexuality education, traits in the individual or traits in the family that interfere with sexual health, and then problems at the societal level that interfere with sexual health. So I'm going to start by talking on the next slide here about sexuality education. A couple of minutes ago, I referenced the Hancock, Stokes, and Mesabov study from 2017. And it's funny, I had written part of this slide before that came out, and luckily their findings matched what I was finding clinically, so it's always nice when that happens. And what they had found is that people on the spectrum are getting less sexuality education than typically developing people. And when we talk about sexuality education, it takes a couple different forms. We have formal sexuality education, which is the sex ed class that most of us picture when we hear the term sexuality education. And it doesn't happen in autism for a lot of reasons. Often individuals who have an IEP are already pulled out for speech therapy, they're already pulled out for OT, they're already pulled out for their social group or whatever else they're doing during their day. And sometimes that sex ed time is the time that goes. That's the time they use. I see that happen more often than not. I've also seen a number of students who are in maybe a life skills program, a program with people with intellectual disabilities, and it just gets skipped. They're focused on a functional academic curriculum perhaps, but they're missing kind of this important bit. Or if it happens, quite often the formal education happens poorly. So you can imagine your patient who has an average IQ and okay verbal skills who can participate in the general education setting, but when he's taken and dumped into a general education sex ed class, it can be very, very difficult for a lot of reasons we'll talk about in a minute. So if that instruction isn't individualized for autism, it may not be adequate. There's also informal education, and this is where most of us learned most of what we know about sexuality, frankly. I'm sure each one of you can think back to 3rd, 4th, 5th, 6th grade when you learned what different terms mean. And the slang terms, the ones you're not taught in the class, right? And those are the ones that end up being so important for understanding what's going on. We also get a lot of information about sexual norms from our peers in terms of their reactions to things. So you say something like, oh, I'm thinking of asking Sally out, and when your friend just looks completely aghast, you're getting information there. You're beginning to put something together to understand. People with autism may have many fewer opportunities for that kind of peer interaction, of course. And then even when it occurs, they may not be taking the same information from their peers. They might not be learning that informal information in the same way. The other piece, and this next piece is one of those things I had mentioned at the beginning that almost has nothing to do with autism, because this is true for all adolescents all the time. But there's a big problem with the sources of information. So if people aren't getting sex ed from formal and informal education, where is it coming from? And for so many adolescents, it's coming from pornography. And I've tried really hard to get good concrete numbers on how many kids are looking at pornography and at what age they're looking at pornography. And I can find bits and pieces of things, but as you can imagine, there aren't good studies on this because, number one, kids aren't going to report it, and number two, it's very tough to get a pornography and children's study past the IRB. There was an analysis in the UK, though, and they were looking at how often children were reported having gone to pornographic websites. And this is from I believe it's almost like a cable company, like the National Cable Association in the UK. I might not have that quite right. But their data showed that even elementary age students, a pretty high number, about 3% of the population was encountering pornography online. That doesn't sound that high until you think how young an elementary age student is, and then you also think it's not really the Playboy of, you know, the 1980s that they're looking at, they're often seeing something very, very graphic and very complicated. So that can give bad information for a number of reasons, and we'll talk more about those in a minute. Another source of information that I'll talk about in more detail too is film, television, and YouTube. So when people with autism haven't had direct instruction in what relationships are and how relationships develop and what intimate relationships and sexual relationships mean, they piece it together for themselves. And they use film, television, YouTube clips, social media, pornography. They use this information to kind of create for themselves their own sexual education program. So moving to the next slide, which is media as sex ed and what the problem is with that. There's unfortunately a lot of misinformation that comes across if a person is only learning about sex through pornography. In pornography, everyone is ready to have sex all the time. Everyone has sex with everyone else. Everyone does everything, right? All of the moves are on the table. There aren't discussions about consent. There very rarely are condoms used. So there are a number of unhealthy sexual behaviors that happen in pornography, and my list was not remotely comprehensive. So that if that's a sole source of sexuality education, it's a real problem. The other problem is if individuals on the spectrum are only kind of gleaning information online, as I alluded to earlier, they're kind of putting it together for themselves and trying to make a story for it or make an understanding of it for themselves. And they very often get some pretty distorted ideas. I'm going to talk about that in more detail in just a second. But one thing I want to mention before I move on is how powerful the impact of visual stimuli is in autism. So most of us, if we're not using it ourselves, we know that others are using images and video as intervention tools for our patients. So we have, you know, video modeling, which is based on Albert Bandura's social learning theory. We're constantly using pictures to show what behaviors are expected and what behaviors are appropriate. We also know it's really common for people on the spectrum to watch videos and emulate what they see in the videos. They love acting out favorite movies and favorite scenes, right? And so it's reasonable to think that in the absence of clear and concrete information about relationships and sexuality, people on the spectrum are going to fill in those gaps with information that they've pulled out of these online sources or other media. And so I want to give a couple examples of this that, again, this is going to fall into my warning from the beginning that I'm going to be a little bit alarmist. I'm probably over cautionary here in some of my tales. But the next slide is just some pictures. And what you see on the left are some very childlike looking figures. There are some anime characters. There's Betty Boop in the middle. And they're illustrating a concept called neoteny. As I'm sure you all know, a lot of our patients are really drawn toward the anime style characters. And those anime style characters have a lot in common with that Betty Boop style in that they have a very large head and very large eyes. And the idea with styling someone in that way is to have them look childlike, have them look younger. This comes to my attention because I do a lot of cases in which someone with autism is accused of looking at child pornography and very often is in possession of thousands of images of child pornography. And more often than not, it appears that they've first started to look at anime characters. So characters similar to this, and I'm not saying that anime causes child pornography or anything that ridiculous, but as they look at these images, they could get a pretty distorted idea, number one, about how old these characters are supposed to be, and number two, how appropriate it is to view images of people who look this young. The person all the way on the right in the black bikini there is from a video game. And in the Japanese version of this video game, this character kind of disrobes over the course of the game so that the object is to get her down to this outfit. But this character's 13 in the Japanese version of the video game. They did make some changes in the American version, but as you know, a lot of our patients have the Japanese version. So this is an issue again, because without that instruction, without somebody explaining, it's against the law here for us for someone over the age of 18 to date someone who's 13. This is really confusing. They're getting a very sexualized picture of what this individual is like. The other, on the next slide here, the other source of media that I think can be a real problem is what I would call stalker training. And what I mean by this is there are a lot of otherwise pretty innocent seeming movies that have a theme, and it's a theme of a very persistent suitor. A suitor who keeps going back or keeps being aggressive or doing something that's just way beyond the norm in order to get the girl. So here you see Aladdin in the upper left-hand corner. Aladdin only saw Jasmine once and fell in love with her and told whatever lies he had to tell in order to woo her. That's a problem. That's not a good template for how to behave, right? There's something about Mary, which is just below Aladdin there. And here, the main character hires a private investigator to track down his high school girlfriend, which is really alarming. The Notebook, every day for a year, he was writing a letter. In Twilight, there's a guy standing over a girl and watching her sleep. In 50 First Dates, there's just a real advantage taking of learning about the love interest and using that to kind of manipulate. So you can see there's a theme here that these are films in which the main character, who's male, does some kind of stalkery things. Now, most people watching these films understand that this is a romantic comedy or this is a cartoon and this is dramatic and this is for dramatic effect and this is why it happens this way. However, it's pretty easy to picture someone with autism taking this as a template for how to behave in a relationship. And I think that it's important, not that we limit people who have social problems from watching these kinds of movies, but just that we talk with them about what's realistic or not realistic about these films and what real relationships are like. So you can see if you have good relationship education that happens alongside watching these movies or alongside looking at anime, nothing problematic may occur. However, if in the absence of that education and that discussion, you've got a lot of ideas just kind of growing on their own that can be problematic. Okay. So the next slide is about what the ASD traits are that can make sexual health difficult. So in the meta-analysis that I've mentioned a couple times, it was actually 2017, I'm sorry, I see I wrote 2018 on this slide. What we find is that people with autism have greater difficulty adhering to privacy norms. And this fits what we see clinically, right? So common to hear the parents or the school teacher say that, he's just pulling down his pants or walking in where they're not supposed to walk in. The people with autism engage in less social behavior. Again, not surprising. That they have less appropriate sexual behavior, have greater concerns about themselves, get less sexual health education. And then also, they give some caveats because there are a lot of variance among the studies, and that could be in part, what accounted for their findings. Anyway, it's also a problem in some studies among offenders who have ASD, so sexual offenders with ASD. There's a beginning of a suggestion that it might be hard to change some ingrained behavior patterns. It's interesting because we also have a number of offenders with ASD who only need a little bit of education and they only need to understand what the rules are, and then they're gonna never break that rule again. However, there seems to be a subset that's very ingrained in their patterns. And of course, once those patterns are ingrained, they're very hard to change. Okay. The next slide is about potential relationship barriers that are just part of ASD. They're either core symptoms of ASD or they so commonly co-occur with it that you just know it's coming. Social communication is, I think, the most obvious, but social communication is critical when you're developing a new relationship, and in particular when you're having a sexual relationship with someone. This is where consent comes in. This is where reading nonverbal cues comes in. This is when giving nonverbal cues comes in, right? So some pretty crucial behaviors associated with sexuality. I've had a number of patients whose insistence on sameness, so this is a tendency to engage in certain set routines and have difficulty kind of deviating from your routines. So I've had a few patients where their insistence on sameness interferes with their relationship development. One of whom, really sweet, sweet guy who I think would do so well if he could just get over this, but he needs to have dinner at home at 5 o'clock every night. He cannot deviate from that. He hasn't been able to shift from that. And you can see how much that would interfere with dating, and how even if he met a woman he likes, she would pretty quickly get frustrated with that. Sensory experiences associated with ASD are a problem. I have a patient right now who's about a 20-year-old young woman who finally is in a relationship. She's dating another woman she really likes, and she seems really happy, but she doesn't like physical affection. So she doesn't like to be hugged. She doesn't like that feeling. And that's having a pretty big impact on their relationship. Social motivation. So you have sometimes people who are very interested in sex and very interested in having sexual things happen to them, but they don't have the motivation to have the social exchanges that typically have to go along with that. Also interest. I mean, sometimes you have people who just don't have the level of interest that's required in order to get a relationship off the ground and developed. Secondary traits like anxiety, I think, is probably the most prominent here, but also depression and a number of other things could also interfere, of course. And then finally, you have this issue of chronological age, so somebody's actual age usually being much higher than their level of social functioning. So you might have somebody who is 20 years old and wants to date, but his main interests are very childlike interests. So it's hard to find someone who is an appropriate age for him to date, but also has something in common. In terms of family conflicts, which is the next slide, family culture and family beliefs can be a real issue. As we're going to talk about in a minute, it appears that there are higher rates of gay, lesbian, bisexual, and trans orientations among people on the spectrum. And so if the family belief is that any of those things is a sin or any of those things is wrong, there would develop a pretty big conflict if the individual comes out, and that can be a real problem. Sometimes there is poor modeling of social behavior, of relationships. Maybe there's domestic violence or other issues, and sometimes the family just doesn't have a lot of knowledge of their own, and they're not able to do the kind of instruction that's needed. What I see quite often is parents who might be embarrassed or uncertain what to say or what to cover. And then also you have a lot of parents who are so worn out and just exhausted that they can't monitor whether their child is looking at pornography, or they can't find the energy to have that discussion after the movie to talk about being a stalker, or they're just worn out, which is quite understandable, but a real issue. And that caregiver fatigue in particular, but a number of factors can really lead to a lack of supervision online. And so when people from a young age are allowed unsupervised time online, a lot of that misinformation and miseducation we're talking about develops. And that's related to the societal issues that affect sexual health on the next slide here. Internet content is a real issue, and search algorithms, so what comes up when people go to Google and they do a search, are a real issue. It's astounding sometimes to see the images that come up in a Google image search, for example, so that even if you're not looking for pornography, it will often pop up. Even if you're not looking for homophobic comments or other destructive comments, they might come up in a Google search, and that could certainly have an impact on how someone feels or how they begin to think about themselves. You have the naive production and then consumption of media and video games. This could be an issue potentially. So if no one, as we've talked about numerous times already, if nobody's talking to the people with autism about how to perceive these things, and society isn't recognizing the role that they potentially play, that's an issue. Because we have such a focus on the development of academic skills in school, or even some functional skills in school, we often are missing the need for the development of leisure skills and leisure programs. So a lot of young adults will end up having huge blocks of free time and time when they really don't know what to do with themselves. And this is when they kind of end up online or end up with another person, getting into trouble and not having, you know, some structure and some organization to approach that time. Likewise, a lack of adult programming, limited job opportunities, and limited housing opportunities. All those things contribute. So the next slide is interference with sexuality education. We've already hit on the fact that the curriculum is designed for general ed students. It doesn't cover the social curriculum. It covers the facts. It covers what the sexually transmitted infections are, you know, whatever is clear and factual, but doesn't give the kind of explicit instruction in the social curriculum and coverage that's required. And I always like to give the example, when we had sex ed in 5th grade in Illinois, the boys were separated from the girls. And then afterward, you know, we all came together at recess and we were comparing notes. And the boys said that they were told that a girl is like a catcher's mitt and a boy is like a baseball. And they were told about reproduction and how, I guess, how the sperm enters the vagina and so forth, but they were told via this metaphor for baseball that was hard even for these typically developing guys to understand. You could only imagine someone with autism in a class where euphemisms are used instead of clear terminology without visual supports. Learning is going to be a real problem. There are also a lot of assumptions made in sex ed courses about prior knowledge. And what we know among people with autism is they may know a lot about some things, but there may also be a number of gaps. So it's really important not to assume prior knowledge, but to go in and make sure that all of those pieces are in place and all the understanding is in place. I'm going to go to the next slide, which is a picture I made when we wanted a visual to talk about all the problems that could potentially contribute to somebody on the spectrum getting involved with child pornography. And it's not, again, something that most people are going to get involved in. It's certainly not something that's going to affect your average person on the spectrum. But I think there are a lot of themes here of things that do affect the average people on the spectrum that are still relatable. So isolation contributes to problems. The sexualization of children in media, like the neoteny, like we talked about, and some other ways that children are sexualized in media that we don't have time to get into. Limited and poor sex ed. Stickiness. So in autism, you know, there's a real tendency to become preoccupied with particular topics and to return to them and to want to collect them and get fixated on them. And for a lot of kids who spend an enormous amount of time online, pornography becomes the area where they get sticky and where they want to learn more and start searching, which in and of itself, if it's time limited, might not be a problem. But when they think they have to get into every corner and know all about every type of it, it becomes a problem. And then the concept that we've already talked about being older physiologically than you are developmentally or psychologically. I'm going to skip, just in the interest of time, I'm going to skip the next slide, which is about the availability of sexuality education in the US. These next two slides really are just to tell you that it's terrible and that we have some guidelines for what should be included, but there's a lot of leeway that states and even individual school districts have about how much they cover. So there's quite a lot of content that's pretty important for sexual health that isn't covered. The next slide then says domains to address. And this is the recommendation from Planned Parenthood about what are the main key areas that need to be covered in order for sexuality education to be comprehensive. And what I think is really interesting here is if we look carefully at this list, a number of these things aren't just factual, they are social. They are about filling in all of those gaps. So that there's no reason that this framework would have to be any different in autism. It would just have to be the intensity, the explicitness, the direct instruction that might be required might be different. So I want to shift a little sexuality. And so I'm going to talk in two areas, behavior, so sexual behavior, and then sexual identification. So the slide then that says sexual behavior at the top. What we know, and there are different numbers on this, but everybody pretty much agrees that most people on the spectrum desire some kind of intimate relationship, but relatively few attain it. So De Winter, who's the guy from the Netherlands I told you about, he found that about half of people in his huge sample had a relationship, but most studies find an even lower number of people who have an intimate relationship. However, as we're looking at higher functioning populations and as our methods are getting better, it seems like more people with ASD are in relationships than used to be in the old studies, where we were only asking parents, right? So a recent study, for instance, found 73% of their respondents had some kind of romantic relationship. Still very much lower than the general population, but it's getting better. The next slide is focused a little more on asexuality. So there's a thought that there may be more asexuality in autism than in the general population, but it's really not clear. And the numbers in the studies have ranged from around 5% to 33%. So that recent study I was telling you about, the Strun study from 2017, they found that 7% of their group had absolutely no desire to be in a sexual relationship. And that's pretty close to estimates of what asexuality is in the typically developing population. But again, we don't know for sure. And a big part of the reason we don't have good numbers on this is because in all of those early studies, when they were suspecting that asexuality was really high, they were getting that information from talking to caregivers and not from talking to people with autism themselves. So it's probably an overestimate. There's some interesting theories, though, about why asexuality could be higher in autism. And some people have suggested that autoeroticism could explain it. So there's an interest in sex, but it's an interest that someone can take care of by himself, so that a sexual relationship isn't needed. And then another theory, and one that I've seen play out clinically quite a bit, is that people can have such a single focus. So for instance, I have a lot of guys tell me, I want to date, but I'm not going to date until I'm finished with college. I want to date, but I'm not going to date until I've been at my job for 2 years. It's hard to focus on a lot of things at once. In the interest of time, I'm going to move through the next two slides. So you're going to miss the most interesting one, which is some pictures there. And basically what these two slides talk about is whether atypical sexual interests and behavior are more common in autism. And I'll give you the quick version, and that is maybe. It may also be that people with autism just aren't as constrained by social norms. So if they have an unusual interest, they're going to speak more openly about it, or they're going to make it clear, they're going to act on it more often. And I'm going to move on down to the gender identity slide. As long ago as like 30 years ago, there were research studies in which the researchers were realizing that children with autism were struggling to answer, are you a girl or are you a boy? So they just weren't grasping that concept that we have in our society. Most clinicians now who I talk to seem to think that the trans rates really are higher in ASD. And there's still, you know, it seems to be the case in the studies too, but we don't have a ton of data on this. The biggest study I could find is also from De Winter, who we've talked about a couple times. And he found that, you know, a very small percentage are just straight up trans, where they're identifying as the opposite gender. But a huge percentage, you know, 22% of women, 8% of men in his sample did have some gender non-conforming feelings, so maybe a non-binary gender identity. Another study, May, Peng, and Williams from 2017, had a much smaller group of kids, but they found a higher gender variance. So it was at 4%, which was much higher than a non-referred population, but it was about the same as the population of people who were referred to psychiatric care in general. So the next slide is getting into sexual orientation. In the typically developing population, sexual identity is much smaller than sexual behavior. And what that means is people are likely to have more gay, lesbian, bisexual, sexual behavior than they actually identify as or report to. We don't know in autism whether that number is just more equal. So are people with autism more likely to have a sexual identity that's a closer match to their behavior? What we do know is it seems like a pretty high percentage of people on the spectrum are reporting being gay, lesbian, bi, or some kind of other non-heterosexual orientation. So a very recent study, Stokes and George, 2017, found almost 70% of their sample reported being non-heterosexual. So there are higher rates of, in this study in particular, higher rates of homosexuality, bisexuality, and asexuality. And then people were also really disinclined to say that they were heterosexual. And then back to the De Winter study, which is massive. It's the biggest sexuality study I've ever seen in autism. They found definitely that more people with ASD reported bisexual attractions, but it was particularly high among the women in their sample. In the interest of time, I'm going to move down a couple slides to the one that says suicide, because I just want to hit on this idea. The idea is already we know that kids with autism have an increased risk of suicide, at least of ideation. And then what we certainly know is that sexual minority youth, so gay, lesbian, bi, trans youth, have an increased risk of suicide. So it's very concerning, I think, when these things co-occur, that it's very important that we make sure that these are youth who are supported and have good education in place to understand that what they're feeling is okay, and then also have whatever supports they need to make sure that they're developing healthy sexuality. The last couple slides here are about teaching sexuality, and so there's a slide that says what and how to teach, and this is just kind of pointing out how it's important to teach facts, to teach the social aspects, and then why these rules are important. And this is true not just in sexuality, but in almost anything you're teaching an intellectually capable person with autism. You have to explain the why and how it fits and what makes this rule important, because otherwise it's just not going to be meaningful to them. And another slide I want to point out before I wrap up and take questions is slide 38 about talking to caregivers. You know, this is the slide I had at the beginning where I talked about the people who are going to come in and talk to you about sexuality in their child, and it's going to be people who are already worried and those who need to worry. And the next slide covers a couple of general strategies for talking to them. One thing I really like to do is to consider how the individual with autism communicates. And often kids fall into one of two categories. Either they come in talking quite openly about sex and have no shyness whatsoever, or they're very careful, very shy, very quiet, very timid when it comes to these topics. And what I find that's helpful for the more timid and embarrassed types is to encourage parents to make educational materials available. Make sure their book's out. Maybe go ahead and bookmark some links, some websites that are really helpful and good. And to make sure that other adults are available to talk if they're just not willing to talk to their parents. I talk to all parents about putting parental controls on the computer so that their children are not chatting with anybody and they're not accidentally stumbling across material that they're not ready for. And then I encourage all parents to check in with their school about sexuality education and make sure that it's part of the student's IEP. The last thing I'll point out before questions, there are references and there are resources at the end. And then the very last slide has my email and it has a couple of Twitter handles. If you'd like to reach out to me via those avenues, please do. And then I'm ready for questions if there are some again.
Perfect. Thank you so much, Dr. Loftin. That was amazing. I'll leave this slide up so people can view it. And I'll just ask a few questions really quick. One question that was asked was, do you have any suggestions for ways to help or discuss pornography with clients, or if you're a caregiver with your child who has ASD?
Yes. I actually, when I give talks, I very often do a series of slides that are called how to teach about pornography. And I think it's pretty crucial to talk to kids about it because they are inevitably going to encounter it at some point. And one of the most important things I encourage people to talk with kids about is how it's what Dan Savage calls kabuki theater. It's an over-dramatized, really kind of crazy, unrealistic thing that happens. So it's helpful to explain to kids that, this is not the real thing. This is a dramatization. I can, if anybody would like, if you shoot me an email, I can send you those slides that deal with teaching pornography because there are a lot of other aspects. I have a task analysis basically from everything from making sure you clear your browser history so that your younger sibling doesn't come up behind you and see what you're looking at, to where and when it's acceptable, to cleaning up if you masturbate. All of those things that parents don't like to have to talk about, but that are really necessary to teach.
Perfect. Thank you so much. I think that we're going to have to end it there with questions, but we always put these slides and also the presentation up on our YouTube page. So if anyone wants to go through, you can see Dr. Loftin's email and also all of the resources that she's provided us with. Huge thank you, Rachel. This was amazing and super informative, and not a talk that we've heard yet. So we just really appreciate you taking the time.
Oh, thanks so much for having me.
Yeah, of course. And thank you everyone for viewing with us. I hope you all have a lovely Thursday afternoon.